I'm Clare Jacobson, and I'll be talking about our poster, Diagnosis of Chronic Pulmonary Aspergillosis from Clinical and Radiologic Evidence Alone. So a little bit of background about why we were interested in this case. Chronic pulmonary aspergillosis is estimated to have a global prevalence of about 3 million and is often seen in immunocompetent patients with underlying cavitary lung disease. Pulmonary aspergillosis is also a common false positive when performing lung cancer screenings with FDG PET imaging. Our learning objectives for this poster were to discuss diagnosis of aspergilloma from clinical history and imaging alone. So our case is a 74-year-old man who presents to the emergency department with a several-month history of bilateral leg pain, weakness, and paresthesias, accompanied by a 30-pound weight loss and fatigue. He'd had a chronic cough for many years, and over the past 3 years, he'd had 2 episodes of bloody sputum per year. His past medical history was significant for a 240 pack-year smoking history, lifelong employment as a brick mason, and COPD. On physical exam, he was cachectic but non-toxic appearing, and the rest of his exam was benign. We then proceeded to obtain some initial CT imaging out of our concern that he may be presenting with a lung malignancy and a paraneoplastic syndrome. So we obtained a scan and saw a 2.7 centimeter opacity in his right lower lobe with an adjacent calcific pleural plaque and several other scattered nodule opacities. Follow-up PET scan demonstrated increased uptake in the right lower lobe, as well as hilar and mediastinal lymph nodes that were avid, pelvic and inguinal lymph nodes, and the right posterior ethmoid sinus. We decided to go after those avid hilar lymph nodes with EBUS-BAL and had no evidence of metastatic carcinoma in them. Fungal sputum culture, Aspergillus EIA, and Fungitel were all also negative. We then decided to try to obtain a tissue sample from this right lower lobe mass via CT-guided biopsy, which you can see in the imaging below. Our radiology colleagues initially first noticed that in the interval between this initial diagnostic CT and the CT-guided biopsy, this mass had grown significantly in size, as well as was now appearing to be actually a cavitated lesion with some kind of mass inside of it. And from the prone and supine imaging, you can actually see that that mass inside of it is freely mobile and gravity dependent. So in the supine imaging, you can see that it's laying along the posterior wall of this thin-walled cavity. And when the patient flips to receive prone imaging, he now has the ball laying against the anterior wall of the cavity, moving freely with gravity there. So a biopsy was not obtained, and instead he was presented at an interdisciplinary conference that because this was a quickly evolving mobile ball within a thin-walled cavity in the setting of known emphysema as well as known negative PET-avid lymph nodes, that this was very likely an aspergilloma, and that the risk of harm from disseminating this via biopsy was actually higher than the risk that this could be malignant that we would be missing by not biopsying it. So it was decided that he would schedule for close clinical follow-up and repeat CT imaging instead of a biopsy, and at 4 months, CT imaging demonstrated that the lesion was no longer cavitated, decreasing in size, and biopsy was again deferred. And finally, that bilateral leg pain, weakness, and paresthesias that we were initially concerned about were eventually attributed to peripheral vascular disease. So in conclusion, main takeaways for this case report are that these radiologic findings were unique and they were an evolving round mobile mass that was highly consistent with an aspergilloma, and along with his clinical picture were diagnostic alone. And this is in contrast to current clinical guidelines that required diagnosis of a chronic cavitary pulmonary aspergillosis to have radiologic findings, exclusion of other diagnoses, and direct evidence of aspergillus infection. And so for this patient, his diagnosis was really a risk-benefit analysis on his specific situation. So that concludes our poster presentation. Thank you so much for your time. I'd like to thank my co-authors, Dr. Ashore, Dr. Perot, and Dr. Gear. And thank you for listening.